I am Dr. Julie Kieser. I am the director of the Arthritis Rehabilitation Research and Training Center grant and center that supports the State of the Science meeting. And our center is ENACT, which is the Center for Enhancing Activity and Participation for People with Arthritis. I am also an associate professor at Boston University in the Physical Therapy and Athletic Training program, as well as the School of Medicine Clinical Epidemiology and Research and Training group. So for the second talk, we wanted to also kind of provide a global perspective of more of a focus on rheumatological rehabilitation. I think this is an important question for our field. So we just heard very nicely from Dr. Brady the public health impact or the public health threat of arthritis. So why this meeting? Why are we here today? And why should rehabilitation professionals care? Well, the main reason is because of the activity and limitation slide that Teresa showed. 22 million people in the United States are limited to basic activities. Arthritis impacts work, and arthritis is clearly a disability threat. That's why rehabilitation professionals need to care. Rehabilitation professionals need to care because our arthritis population in our patient practices will undoubtedly increase, and we also have the skills to make a difference. But that doesn't address our question that I posed for this talk, and a question that I think we really need to think about and discuss today. Rheumatological rehabilitation, how are we doing? So to address this topic, I will start by taking a look at our past. What was rheumatological rehabilitation like decades ago? I will also discuss some major advances in our field over the past couple of decades. Then I will discuss current gaps and some upcoming challenges, and the future needs of our field as I see it. So first, a look to the past of rheumatological rehabilitation. My predecessor of the NIDER Arthritis RRTC, Dr. Marion Miner, wrote in the book, The ACR at 75, which is a book that commemorated the 75th anniversary of the American College of Rheumatology. And I quote, "In 1965, as I started my career as a physical therapist, my first patient was a woman with rheumatoid arthritis, functional class 4. She had been treated with high-dose corticosteroids for over 15 years and was admitted to the rehabilitation unit for 2 weeks every summer. Her treatment orders were for mat exercises, passive and active assisted range of motion. I had received 1 lecture on rheumatoid arthritis and attended grand rounds about corticosteroids. This was pretty common practice 40 years ago for our rheumatological patients. In the mid-1980s, when I started my career as a physical therapist, physical therapy for people with arthritis generally consisted of range of motion exercises and some gentle open chain strengthening exercise. I remember treating lots of patients with short arc quads, lots of short arc quads, and if things were going well, I added a 1-pound ankle weight. Hot and cold modalities were commonly used by my OT colleagues, and interestingly, there actually was a small, albeit very limited, literature that supported these treatments. The articles were review articles and more case-based, rather than the more rigorous research we see in the field today. But nonetheless, even in the 70s and 80s, there was literature for addressing rheumatological rehabilitation. So during these early decades, when little was known about how to treat arthritis conditions, rest was widely recommended. You got arthritis, just rest and take these medications. Now, things are different. Now we want people to move. We want people to be active, and more importantly, we want them to stay active. Now we want them to be engaged in their complex roles. We want them working. We want them engaged in their community. So let's look at some of the major advances over the field in the past 2 decades or so that may have gotten us to where we are today. There are many advances in the field and a lot of outstanding work, much of it coming from people in this room. I cannot, however, highlight everyone's work, so I'm going to select a few that I think have been instrumental and are critical for the field and going forward. So first, there have been tremendous advances in medicine. The diagnosis of rheumatological conditions is happening much earlier in the disease process, and there are now a number of effective medication regimens that minimize the disease processes or control disease processes. These have resulted in less joint and tissue destruction. Importantly, these medications treat the inflammatory conditions such as rheumatoid arthritis, but they are costly and are not always widely available. For osteoarthritis, which is the most common type of arthritis, medications are not known to manage, and the disease-modifying medications are not known. And despite these advances, there still is no cure for arthritis, and disability persists. The second area in which there has been significant advance is exercise. As I mentioned, in the 1980s, gentle range of motion and strengthening exercise was the recommended rehabilitation treatment. In 1989, Dr. Marion Miner and her colleagues, with support from this NIDER Arthritis RRTC funding mechanism, published a landmark study that showed that people with arthritis can exercise. and they can exercise without increasing their joint symptoms or doing damage to their joints, which was a thought that primarily prevailed in clinical medicine. Furthermore, people actually improved their aerobic capacity and their walking speed. This randomized controlled trial led to many in the 1990s, and in some way the 1990s can be referred to as the decade of arthritis exercise clinical trials. Rheumatoid arthritis and osteoarthritis were the most commonly studied conditions. Then, in the following decade, at the turn of the century, several systematic reviews were conducted that showed that aerobic training and strength training had an beneficial impact on pain, function, and strength. The effects are small to moderate, with an effect on decreasing pain, improving function, and increasing strength. This work has led to the recent published clinical guidelines supporting exercise as a strength training to treat and manage osteoarthritis. And these are supported through American College of Rheumatology, EULAR, and ORZ guidelines. These are prominent professional organizations, both in the United States as well as internationally. The current exercise guidelines for people with arthritis are moderate aerobic activity for 150 minutes per week and resistance training 2 times per week. So looking more specifically at physical therapy or the rehab professions, the APTA orthopedic section has published clinical guidelines for the treatment of hip osteoarthritis, which is great. These were published in 2009. And the recommendations note moderate evidence for exercise, education, and manual therapy, and strong recommendations for performance-based measures. So these might be a little dated, but it's great that we have specific practice guidelines within the rehab professions. To my knowledge, there are no guidelines for knee OA, so I expect that to continue, and there are no guidelines for other rheumatic conditions, which is clearly an area that needs to be addressed. As the scientific evidence increased, community-based programs were developed and evaluated. Several of them are now endorsed by the Centers of Disease Control and Prevention. The Walk with Ease program, the Arthritis Foundation Exercise Program, Active Living Every Day, Fit and Strong, which we will hear about later today, Enhanced Fitness, and the Arthritis Foundation Aquatic Program. Now we just need people to go to these programs. The third area that has seen major advances over the past 2 decades is arthritis work disability. Premature work cessation was identified as a significant outcome in arthritis in the 1980s. Studies showed up to 50% of people with arthritis, clinical populations, were unemployed within 10 years of diagnosis. These early studies identified disease duration, disease severity, physical functioning, and work-related factors to be important risk factors. In the 1990s, factors associated with return to work began to be studied. Not necessarily just looking at just as people stopping employment, but what gets them back to work. And this early work showed the importance also of work and organization factors. Measurement of work disability also began to be a major focus. So what specific types of work outcomes do we need to look at, and how do we measure them? And the epidemiology of work loss continued. At the turn of the century, we started seeing randomized controlled trials designed to sustain employment. Early work showed beneficial outcomes of employment retention programs and job satisfaction with vocational rehabilitation approaches from my colleague, Dr. Sarah Lynn Allaire. This has also led to the investigation of other approaches, such as ergonomic approaches, occupational therapy, and exercise, with these studies having a positive impact on self-efficacy, fatigue, and some of the work performance outcomes. The fourth area I want to mention is the recognition that participation and engagement in life situations is an important concept for people with arthritis. The concept of participation brings the impact of arthritis to life from my perspective. Are people working? Are they engaged in their community activities? Are people participating fully in their life, in their social roles? Recognizing that participation outcomes are important has brought a renewed recognition, noting that optimizing people's engagement in desired life activities is a critical goal of rehabilitation. The term participation comes from the International Classification of Functioning, Disability, and Health, for the ICF. The ICF is arguably the predominant disablement enablement framework in guiding the rehabilitation field today. The ICF offers a conceptual framework for us to look at how body structures and functions are related to the activities that people do and subsequently participation. The ICF also notes the importance of the environment and person-level factors in these relationships. In the ICF, activity is defined as an execution or a task of an activity by an individual, and participation or participation restriction is defined as involvement in life situations. Many of these participation items or domains are looking at the complex roles and are comprised of multiple tasks and activities. Indeed, recent research does show that people with arthritis do have participation restrictions. Data from the 2009 National Health Interview showed that 11% of adults with arthritis have restrictions in social participation. In a more high-risk group, we found that almost 38% of older adults with symptomatic knee OA and functional limitations had moderate or severe participation restriction. So it seems to be something that people are dealing with. They might be limited, but does it matter? So this was a study that was published in 2008 that showed that people do view these social activities as important. So on the left, the scale ranges from not at all important is a 0, and the 5 indicates extremely important. And the types of activities that were asked were relationships with family and friends and other people, physical and leisure activity, travel or vacation, hobbies, intimate relationships, social contact with others, and community activities. And indeed, people with arthritis with OA, and it has been shown with other conditions, do view participation in these activities as important. However, their satisfaction with their performance of the activities and their satisfaction with the time spent doing these activities is not as high, coming in at more of the moderate level. So we have a gap. People view these as important to them, they want to do them, but they're not satisfied with their performance. So it is nearly impossible to talk about advances in outcomes without talking about advances in measurement. And there have been a number of advances in measurement over the past area in the area of participation. Our new investigator workshop yesterday addressed some of these advances, but some of the measurement instruments that I just wanted to highlight, there are many now in the area of participation, but the PROMIS, the OA CAT, the impact on participation and autonomy scale, the Kiel assessment of participation, the social role participation questionnaire, the participation objective, participation subjective, and the late life disability instrument. Another important area of measurement I wanted to briefly mention is the outcome measures of rheumatology group, or the OMERACT group. OMERACT is an international effort that over the past 20 years that has strived to develop and validate clinical and radiographic outcomes for rheumatic conditions. It's a wonderful group. They have many subgroups, and the one I wanted to highlight was the work productivity group, as we measure, looking at different ways to measure work productivity and our work outcomes. These major advances in rheumatological rehabilitation have followed impressive trends in the literature, and I wanted to just take a moment to talk about these. So I conducted a PubMed search on arthritis and osteoarthritis, and I looked at outcomes that we look at commonly in rehabilitation: pain, function, disability, and social participation across 4 decades. And as we can see, we see impressive increases, with each decade almost doubling the previous decade. This is very general. It includes surgical and medical approaches, so it's not just from a rehabilitation perspective. But as you can clearly see, there's a significant increase in the literature, and with most of the emphasis being on pain and function. Social participation, not surprisingly, does not have as much. It's a newer concept in the field, so that's making sense. For those of you who are looking at pain as a primary outcome and you're sorting through 7,000 articles, good luck to you. So overall, we have had tremendous advances in rheumatological rehabilitation over the past several decades. These are fireworks over the city of Boston. Boston's very beautiful in July, yet gaps remain. So what are those gaps? The first gap is exercise. We know exercise is good, it's widely recommended in practice guidelines, yet adherence remains a problem. The majority of people with arthritis do not exercise, and even fewer people engage in recommended levels of strength training. Dr. Hughes, Baker, and Rimmer will address this topic later today. The second gap, from my perspective, addresses the continued presence of work disability. Rates of premature work cessation remain high, and work limitations remain high. We have some but limited evidence regarding interventions to sustain employment, minimize work limitations. Furthermore, we need research that translates the effective approaches to practice, such as Dr. Brady mentioned. Presentations this afternoon by Drs. Pransky, Baker, Jacobs, and myself will address these gaps. The third gap, from my perspective, pertains to participation. This is a new concept in the field, and we need research that identifies effective strategies to enhance participation, as well as participation in the clinical context, including how clinicians can enhance, or including the clinical context, sorry. Presentations by Drs. Fitzgerald, Dr. Murphy, and Dr. Maxwell will address these gaps. The fourth gap relates to pain. We have known for decades that pain is an important factor for people with arthritis. There is recent research, particularly with OA, that is looking at the roles of peripheral and centralized pain mechanisms in pain reporting. There's also ongoing research understanding the complexity of pain reporting. What type of pain do they have, and how is it related to what their outcomes are? Dr. Murphy will discuss this in her talk later this morning. The final gap I wanted to highlight, and by no means is it the last on the list, is the disparity in disability and service utilization among minority and non-minority populations. Minority populations experience more disability due to arthritis than non-minority populations and are less likely to receive knee and hip joint replacements. While we are not specifically addressing this topic today, it remains a critical area for our field. So looking to our future, we need to think about some other broader issues that may also have an impact on our field. The shifting demographic of our society in our population is nothing new, that's to anyone in this room. But the shifting demographic will mean more people working who are going to be at work with arthritis who will be at risk for work disability, as well as just the growing number of people with arthritis in the population. Second, obesity continues to increase in our society at a remarkably high rate. We know obesity is a risk factor for arthritis. It has an impact on musculoskeletal health outcomes. It will continue to be an impact in our field. Third, there's some evidence that suggests that the reports of knee and hip pain may actually be increasing. This is even after adjusting for radiographic OA and obesity. Why people are reporting more pain is not well understood, but it could have an impact on the strategies people seek to treat their pain. We have an impact on our healthcare system and on rehabilitation. Fourth, the rates of knee replacement are skyrocketing. Between 1991 and 2010, the rate of knee replacement increased by 161%. A JAMA special issue published in 2012 identified that joint replacement was a health priority and called for close outcome measurement of this procedure and the identification of people who can respond to the procedure and those who do not. The last major influence I wanted to mention is technology. And technology can be really good and it can be really bad. What I am amazed with technology is when it works, it's great. When it doesn't, it's not good. But what I am intrigued about with technology is we are developing more and more ways to look at how people move and what they're doing for their daily activities. But I'm also very intrigued by people like these gadgets and whether or not we're going to have some sort of a switch where we can actually start getting into more of the health preventive behaviors because people like these gadgets. I don't know, more of the younger population, but is yet to be seen. But we are in the information age. So this leads us to some critical needs of the field. 1, better outcomes for rehabilitation therapies. 2, better ways to foster physical activity adherence. And 3, better ways to promote employment retention. We need interdisciplinary approaches. These are complex problems. We need all of us sitting around the tables working together to address these problems. So our objective for today's meeting is to create a dialogue among experts in the field, that would be you, with the goal of moving the arthritis activity and participation research agenda forward. I heard yesterday lots of comments about how we really need to figure out how to do this, and we need to have those conversations, and we hope that this meeting allows us to have those conversations. So in our first session, we will address promoting activity and participation in the rehabilitation setting. Dr. Scott Hassan will moderate this session, which will be followed by a 15-minute interaction with you. Our first first presentation is knee pain and osteoarthritis, looking at both physical therapy and occupational therapy approaches. To my knowledge, this is the first time that we have had PT and OT talking about a joint approach to knee pain. Second, we will have a critical look at total knee replacement outcomes that will be given by Dr. Jessica Maxwell. In our second session, we will address promoting activity and participation at the community. This is primarily addressing physical activity promotion. This will be moderated by Dr. Alan Jetty. Our first talk will address behavioral strategies to improve adherence. That will be given by Dr. Susan Hughes. The second talk is innovations in technology in improving physical activity adherence, and that will be given by Kristen Baker. And our third talk is environmental approaches for promoting physical activity adherence in people with chronic conditions and disability, which will be given by Dr. James Rimmer. Our third session is promoting activity and participation in the context of employment, and this will be moderated by Dr. Catherine Bachman. Our first talk addresses innovations using technology to close the gap between the clinic and the workplace, be presented by Dr. Nancy Baker and Dr. Karen Jacobs. Our second talk is employer innovations for sustaining employees. What does the science say? This will be presented by Dr. Glenn Pransky. And our third talk is community-based interventions to sustain employment, and I will give that talk. Lastly, we will follow up, we will go back to policy, and looking at policy perspectives from the United States and from Canada. Dr. Patience White will look at addressing perspectives from the US, advocacy, access, and research for a cure, and Janet Yale will discuss perspectives from Canada, looking at models of care. Lastly, we will follow up with a stakeholder, a panel, and an interactive discussion with all of you. So I leave you with the question, rheumatological rehabilitation, how are we doing? This is an important question for us, and I hope our dialogue will shed more light on this throughout the day. I wanted to briefly mention our team at BU for the center. We have people from Sargent College, School of Communications, and School of Public Health, so it's a nice interdisciplinary group that allows us to accomplish our activities. We can't do it without the interdisciplinary perspective. I'd like to thank you for your attention. I know I went fast because I tried to catch us up on time a little bit. I would like to acknowledge my colleagues, most importantly, also our funding source from NIDAR for the arthritis RTC. So I think we will go to break, and we're back at 10:30.